So here, taking a slightly closer look at the rotator cuff as a group, not as individual muscles. So very generally speaking, when we talk about the rotator cuff, we're talking about supraspinatus, infraspinatus, teres major, and I always screw that up, so if I made a mistake there, please excuse me, and then subscapularis. The big deal that we're looking at is that as a group, the rotator cuff tendons go this way. So their main job as a group, so as individual muscles, internal and external rotation, but as a group, what they do, because their tendons pull this way, so as the muscles contract, they're going to pull the humerus towards the glenoid, so the humerus essentially doesn't fall off the body. If we're looking at figuring out what to do with the rotator cuff, I can't tell you what to do with every rotator cuff or with every shoulder, but what I can do is identify ways that makes it a little bit easier for you to access the rotator cuff generally, or work around the shoulder. So in lateral recumbent, you have a very good opportunity to work through the muscle bellies of the rotator cuff, because the muscle bellies, generally speaking, are here, right? So we know that we are looking at the scapula. We know that the easiest landmark to find on the scapula is the scapular spine. Okay, so we're going to look at our concepts of of palpation. So please excuse me. Specificity is not the number one necessity, so we don't have to be able to pick out each muscle belly. Absolutely, right? We need to pick out what doesn't move, so specificity is not the number one necessity. Movement is. We're moving from the known to the unknown, so I know the scapula is going to be somewhere in here, so I can then go ahead and use the third concept, get as much as you can touch, so I can visually look right here, I can palpate, and as I push in, I'll note what is soft versus what is hard, so I can identify the bone. So the second I identify the bony landmark, okay, it's not perfectly visible here just because of angle, but I identify the bony landmark. If I go above it, I have supraspinatus. If I go below it, I have infraspinatus. Yeah, so and then what I can do is I can broadly push through. So I want to motion test the soft tissues. I can broadly push through them. I can identify anywhere in my hand that doesn't yield very well, and then I could go apply specific treatment there. Now I don't absolutely have to do that, but what I want you to understand is that if I want those muscle bellies and to identify where there may be a problem, is I broadly contact, I identify the scapular spine, I move above it, I move below it, I push into those soft tissues to identify what does not yield, then I can treat. So I don't want to start with a fine tool or a small tool, I want to start with a large tool, so going from big to small. So the concept in assessment, macro identifies micro. This is macro. Anywhere in my hand that doesn't yield is micro, and I can go and I further identify. Now, if we want to talk about accessing the musculotendinous junctions of the scapula, or rather of the rotator cuff, right in here, right in the space between the scapula and the humerus is where we can access it. Now, this isn't ideal based on the shot, but what I can do is I can show you that if I get into the axilla, so I can open up here, the second that I get in there, I can wrap around and I can contact lat, teres major, teres minor, I can get some deltoid, and then I can start to work through all of that. As I wrap around the front, I can get into subscapularis, or at least the muscle belly of subscapularis, if the scapula comes away from midline, and I can identify or really free up more of that. So what we're going to do here, just lift your arm up. Okay. There we go. So what you're going to see here is that I've exposed, right? So right through here, I've exposed some of the musculotendinous units of the rotator cuff. So I'm missing supraspinatus, and I have picked up some of lat, latissimus dorsi, and I've got teres major, teres minor. I may have some infraspinatus, but it may not be perfect, right? But what I can do is with this yoke hold, I can wrap it around here, and I can, again, use that broad contact, identifying what doesn't move, what doesn't yield. As I push in, as I move around, I can identify all of that, and then I can create treatment. So I create treatment off of a broad hold, identifying many structures, right? So if I want to look at those tendinous units, now if I wanted to look more so at subscapularis, what I'm going to have to do is come in here. I'm going to have to get the arm up. Now, I'm seated just to try to display some things. This isn't absolutely the way I would do it, but from this hold, from this yoke hold, all I have to do is wrap around into the axilla on the posterior surface. So I'm behind the patient, so as my hand wraps in and forwards and comes back towards me, then I'm starting to contact the muscle belly of subscapularis. So again, just trying to give you some access routes. Now this is exactly the same when the patient is in supine. So I'll have you lay on your back. The only thing is now that this side is towards me, I can still take this yoke hold, I can place it in here. Now you can see that I'm all the way around, whether I want deltoid, subscapularis, teres major, teres minor, latissimus dorsi. I'm going to have a hard time getting into infraspinatus and supraspinatus just because of where they are, but I can contact a large amount of the rotator cuff simply there. Right now, I would position myself differently as I would treat it, but I can work through all of those things. So I can push up on the soft tissue, right? If I move closer to the humerus, that becomes a glenohumeral glide, but I can push through that soft tissue. I can contact all of it. Same deal. If I want subscapularis, I come into the axilla, wrap my hand forwards, and push towards the posterior surface. Now, I could sit here and tell you that I'm specifically working on one muscle or another, but I'm going with that concept with our palpation, that specificity is not the number one necessity, movement is. And also our concept from assessment, movement is the number one thing we're working on. So I'm going to work on what doesn't move, regardless of what structure it is. I don't have to specifically name it, but I have to know what I'm in the region of, what I'm getting an opportunity to work on. So those are kind of your access routes for a large portion of the rotator cuff. Now, the other thing to consider with shoulder dysfunction is the biceps and the biceps tendon and the pectorals. We can speak about that at another time, but it's the same concept. Get as much as you can touch. Right? Specificity is not the number one necessity. Movement is you treat what doesn't move. You don't treat a specific structure, you treat what doesn't move. And we can talk about that another time.